Welcome, deep divers. Beyond that rhythmic beat, we often just, well, take for granted your heart is this absolute marvel of biological engineering, powering an entire internal universe inside you.
It really is quite something.
Today, we're embarking on a comprehensive journey into this incredible system, specifically a deep dive into the cardiovascular system.
It's truly astounding when you stop to think about it.
Yeah.
From the earliest stages of development, long before birth, right up until your very last breath, this organ performs a nonstop, perfectly orchestrated symphony. Contraction, relaxation.
Yeah,
It's a testament to nature's incredible design, really.
it certainly is. And our mission today is to try and unravel this complex network. It includes not just the heart and that intricate web of blood vessels, but also the often overlooked yet absolutely vital lymphatic system.
That's right. Our goal here is to pull out the most profound and crucial insights from the material you've shared,
Mhm.
basically give you a real shortcut to being well-informed.
Right.
We want you to grasp not just what these components are, but really why they matter so profoundly, especially when we think about them in a clinical context.
Yeah, the why is key.
Understanding this system is just fundamental to grasping a huge range of health and medical topics.
Think of this as your personal expedition, everyone, to gain that foundational knowledge that will hopefully spark some aha moments.
Exactly.
It's about connecting the dots, right?
Uh,
Between seemingly separate pieces of information, allowing you to truly understand some of the most common and, frankly, critical health issues that affect so many lives.
So let's get you informed.
Let's do it. Let's start our deep dive. Okay, so to really get a handle on this complex system, maybe the best place to start is with a kind of a grand overview, laying out the major players and how they fit together within the broader circulatory system. What are its fundamental divisions?
That's an excellent starting point. Because, surprisingly, the terms circulatory system and cardiovascular system often get used interchangeably, even though they're not quite the same thing.
Ah, okay.
The broader circulatory system actually includes two primary divisions.
Hmm.
The cardiovascular system, which is, what most people immediately think of,
Heart and blood vessels.
and the lymphatic system.
Ah, the lymphatic system.
Yeah.
Okay, our source material really highlights this. It's often shown in green in diagrams, right? And frankly, it gets far less attention than it deserves. But the material insists it's extremely relevant and should never be forgotten. Can you give us a quick preview of why it's so important before we maybe circle back to it later?
Absolutely. And it is extremely relevant. So while the cardiovascular system is all about transporting blood.
Delivering the goods.
Yeah, exactly. The lymphatic system acts as the body's essential drainage and surveillance network. Imagine your body is like a bustling city. The cardiovascular system is the main road network, delivering supplies, taking away waste, that kind of thing.
Makes sense.
The lymphatic system, though, it's the crucial, often unseen, waste management and security system. It collects fluid that naturally leaks out of the blood vessels.
A little bit of leakage is normal then.
Oh yeah, totally normal. It collects that fluid, cleanses it, and it's a vital part of your immune defense, constantly checking for threats like bacteria or viruses.
Mm-hmm.
Its role in fluid balance and immunity is just paramount. We'll definitely dive deeper into that later on.
Okay, good.
But for now, yeah, let's hone in on the cardiovascular system itself.
Perfect. So the cardiovascular system, breaking down the name, cardio for the heart, vascular for vessels. So it's essentially those two main components.
Precisely. You've got the heart, the central pump, the incredible engine driving everything. And then you have the blood vessels, which are that intricate network of pipes, basically, tubes that transport blood all throughout the entire body.
Okay.
That really sets the stage for our journey today.
All right, now that we've got the big picture, let's nail down some fundamental rules about these blood vessels, because surprisingly, what many of us think we know about arteries and veins isn't, well, entirely accurate. There's a common misconception we need to clear up right away.
Yes, this is a really critical distinction. It often gets muddled, and understanding it correctly is foundational. Let's start with arteries. The precise anatomical definition of an artery is simply a vessel that sends blood away from the heart to a tissue.
Away from the heart.
The directionality is absolutely key here, always moving blood away from the central pump.
Got it. And then the flip side, veins.
Conversely, the precise definition of a vein is a vessel that brings blood back to the heart from a tissue. Again, direction is everything. Blood flowing back towards the heart.
Okay, back to the heart, regardless of what's in the blood.
Exactly. And this leads directly to debunking that very common misconception.
Mm-hmm.
Many people are taught, or maybe just assume, that arteries always carry oxygenated blood, the red stuff. and veins always carry deoxygenated blood, the blue stuff.
Yeah, I think that's what most people picture.
But that is fundamentally incorrect. The distinction between arteries and veins is not about the oxygen content of the blood within them. If you based your understanding just on oxygenation, you would fundamentally misunderstand a huge, crucial part of the circulatory system.
Wow. Okay, that's definitely a massive aha moment right there for many listeners, I'm sure. It really challenges a deeply ingrained idea.
It does.
And our source material specifically hints that the pulmonary circulation, that's the path of blood to and from the lungs, is going to be a prime example of this very exception.
A perfect example.
So keep that point in mind, everyone, as we start navigating through the chambers of the heart itself. Okay, let's truly unpack this marvel, the heart. It's a four-chambered powerhouse, but before we trace the blood flow, we really need to get our bearings straight on its anatomical position. Looking at diagrams can be incredibly tricky sometimes.
Oh, absolutely. This can definitely be a bit confusing at first, especially when you're looking at a flat two-dimensional diagram. Your instinct might be to think, okay, that's the left side because it's on the left of my screen.
Right. My left.
But anatomy has this fundamental universal rule.
Hmm.
You always orient yourself as if the anatomical subject, in this case, the heart, is facing you. It's called the anatomical position.
Right. So if the heart were a person standing right in front of me, facing me, its right side would actually be on my left and its left side would be on my right. It's kind of a patient-centric rule, always from the perspective of the body you're examining.
Exactly that. So applying this rule, when we look at any diagram of the heart, what appears on your left is actually the heart's anatomical right side, and what appears on your right is the heart's anatomical left side.
Okay, I got to flip into my head.
Yeah, you do. And this foundational understanding is absolutely crucial for correctly interpreting heart diagrams and, maybe more importantly, for understanding the correct pathway blood takes through its chambers.
Now that we're properly oriented, let's embark on that incredible journey of blood flow through these four chambers, truly the flow of life. Our source material calls it the core dots and lines scheme, which I like. A simplified way to visualize this continuous circuit.
It is a continuous circuit. And the heart, as we know, has four distinct chambers. Two atria, sometimes called auricles, because they have these little ear-like flaps. They're at the top.
The receiving rooms.
Pretty much, yeah, the receiving chambers. And then two ventricles, which are the larger, more muscular pumping chambers down below. These four chambers work in perfect synchronicity to ensure blood gets propelled efficiently.
So if we think about their distinct roles, the atria are primarily the receiving chambers. They always, without exception, receive blood returning to the heart.
Always.
And based on our earlier definition then, since blood always returns to the heart, this means that veins, by definition, always arrive at the atria.
That's a constant vital rule.
Yeah.
Correct.
Right.
In contrast, the ventricles are the expelling chambers. Their fundamental job is always to pump blood out of the heart.
The pushers.
Exactly. So logically following our definitions again, arteries always exit from the ventricles because arteries are, by definition, vessels taking blood away from the heart. This clear functional distinction simplifies understanding the heart's overall purpose.
So let's follow the actual path.
Right.
We'll start with the deoxygenated blood coming back from the body, the used blood that's delivered its oxygen and picked up waste. How does it first get back to the heart?
Okay, so this deoxygenated blood, which we'll think of as blue, collects from the entire body through this vast network of peripheral veins. These smaller veins then merge and converge into the two largest veins in your whole body, the superior vena cava and the inferior vena cava.
Okay, superior and inferior. Makes sense.
The superior vena cava drains all the deoxygenated blood from everything above the heart, your upper body, arms, head.
Okay.
The inferior vena cava handles everything below the heart, your lower body, your legs.
Got it. And both of these huge vena cavas then dump all that deoxygenated blue blood directly into the
right atrium. That's the first receiving chamber on the heart's right side.
Okay, first stop.
From the right atrium, the blood then flows downward through a valve into the right ventricle. This chamber is the starting point for blood's really crucial journey to pick up more oxygen.
Right, it needs to get refueled.
Exactly. So from the right ventricle, that deoxygenated blood is then pumped with considerable force into the pulmonary artery. Now, here's where that critical rule we talked about really matters.
Ah, okay.
This is an artery because it's sending blood away from the heart, even though in this specific, very important case, it's carrying deoxygenated blue blood.
The big exception.
The big exception. The pulmonary artery then quickly branches, taking this oxygen-poor blood directly to the lungs for that vital exchange of gases. This whole circuit right side of the heart to the lungs and back, that's what we call the minor or pulmonary circulation.
So once that blood gets to the lungs, it goes into tiny vessels, drops off its carbon dioxide waste for us to breathe out, and picks up a fresh load of oxygen, turning bright red again.
Correct.
This freshly oxygenated blood then makes its return trip from the lungs via the...
Via the pulmonary veins. Again, another critical point here.
Okay, veins carrying red blood.
Exactly. These are veins because they are bringing blood back to the heart, even though they are now carrying highly oxygenated bright red blood. These pulmonary veins then deliver their oxygen-rich cargo to the left atrium.
Okay, so now we're on the left side, the oxygenated side.
Yep. From the left atrium, that oxygenated red blood passes through another valve into the left ventricle. And the left ventricle, well, this is the true powerhouse of the heart.
The main pump.
The main pump. It then propels this oxygenated blood with immense force into the aorta. The aorta isn't just the largest artery, it's the most vital artery in your body. It acts as the master distributor, sending that life-sustaining blood to your entire body, literally every single cell, head to toe.
And then the incredible cycle just keeps going. That oxygenated blood gets used by the tissues, becomes deoxygenated again, picks up waste, returns via veins to the right side of the heart, starting the whole loop all over.
Exactly. Continuous, perfectly balanced.
So just to recap that bit. The right side of the heart handles the minor or pulmonary circulation, deoxygenated blood to the lungs and back. The left side handles the major or systemic circulation, oxygenated blood out to the whole body and back.
You've got it. It's a continuous, perfectly balanced system. And this continuous demanding work brings us to a really crucial point about the left ventricle specifically. It is, without a doubt, the largest and most muscular chamber in the entire heart.
Yeah.
And there's a very logical biomechanical reason for this.
Yeah.
It needs to generate enormous force to do its job.
That makes perfect sense. It has to pump blood to the entire body against significant resistance, covering a huge distance, head to toes. It's like a supercharged engine, right? A real workhorse, way stronger than the right ventricle.
Way stronger. The right ventricle only has to pump blood to the nearby lungs. That's a much shorter trip, much lower pressure, far less resistance.
Right.
The difference in workload is immense. If you were to actually hold a heart in your hand, an anatomical specimen, the apex, the tip of the heart, that's actually formed by the left ventricle.
Oh, interesting.
And you'd immediately feel how strong, thick-walled, incredibly firm it is. In stark contrast, the right ventricle feels noticeably softer, thinner-walled. It just doesn't need to generate nearly as much pressure.
Wow.
And this difference you can actually feel directly correlates to the big differences in blood pressure. Systemic circulation, driven by the left ventricle, has very high pressure. Pulmonary circulation, driven by the right, operates at much lower pressures. Understanding the pressure difference is vital for, well, understanding many cardiac conditions.
Okay, let's keep this amazing journey moving. As blood flows through the heart, it absolutely has to move in one specific direction, one way only. And that's where the heart's gatekeepers come in, the valves. They're essential for making sure the flow is efficient.
Think of them as incredibly sophisticated plumbing structures inside the heart. Their main job is to act like a series of one-way doors. They ensure blood flows one direction and not the other, as the source says. They completely prevent backflow, or what doctors call regurgitation.
No going backwards.
No going backwards. They guarantee the blood sticks to its correct, continuous circuit. Without them, the whole system would just descend into chaos pretty quickly.
So how do these biological doors actually work? The source explains it quite nicely. The structure allows blood to fill in behind these little flaps, the cusps. Then, if blood tries to flow backward due to pressure changes,
the pressure itself causes the cusps to just snap shut, sealing the opening. It's an incredibly efficient, really robust mechanical design. Allows the heart to maintain that forward propulsion with every single beat.
Okay, so moving from the receiving chambers, the atria, down to the expelling chambers, the ventricles, we hit the first set of valves, the atrioventricular valves, aptly named.
Yep, located right between the atria and ventricles. You might also hear them called auriculoventricular valves in some older texts, but they mean the same thing, critical structures.
And on the right side of the heart, separating the right atrium from the right ventricle, we have the tricuspid valve. Gets its name because
it literally has 3 leaflets, or cusps, those distinct flaps that open and close. Try, be free.
Simple enough. And on the left side, between the left atrium and left ventricle, we find the bicuspid valve.
Bi meaning 2. This valve uniquely has just 2 leaflets, but it's also very famously known as the mitral valve.
Oh, the mitral valve. I've heard that one. Why mitral?
Supposedly, it resembles a bishop's mitre.
Mm.
That distinctive two-pointed hat bishops wear.
Okay, I can picture that.
Or, as a simpler mnemonic, sometimes people think mitad, like half, for two leaflets. Its proper function is absolutely critical for maintaining the high pressure needed for systemic circulation.
Got it. Okay, next up, as blood leaves the ventricles and enters those big arteries, the pulmonary artery and the aorta, it passes through another set of crucial valves, the semilunar valves.
These are also sometimes called sigmoid valves. They get their main name, semilunar, from their shape. If you looked at them from above, they have this distinctive crescent moon or curved shape, semilunar like half moon. They're structurally a bit different from the AV valves, designed to handle the much higher pressures when blood is ejected into the arteries.
The first one is the pulmonic valve. Name's pretty obvious.
Super obvious. It's located right at the exit of the right ventricle, opening into the pulmonary artery. Its job is just to make sure all that deoxygenated blood goes straight to the lungs, no backflow into the right ventricle.
Makes sense. And the other one?
Equally straightforward. The aortic valve, strategically placed at the exit of the powerful left ventricle, leading directly into the aorta. This valve is under immense pressure, controlling the flow of oxygenated blood to the whole body. Its robust design is absolutely vital. Understanding these names just makes tracing blood flow much easier.
Now, here's a really cool clinical connection that brings these valves to life. When a doctor or nurse listens to your chest with a stethoscope, they hear that familiar lub-dub sound. What are those sounds? It's not the heart muscle squeezing, right?
That's exactly right, a common misconception. The lub-dub sounds, medically termed ruidos cardíacos, or heart sounds, are specifically the audible sound of the valves closing, not opening, closing. The lub, that's the first heart sound, or S1, is produced when the atrioventricular valves, the tricuspid and mitral, close simultaneously as the ventricles start to contract.
Okay.
The dub, the second heart sound, S2, is produced when the semilunar valves, the pulmonic and aortic, snap shut as the ventricles finish ejecting blood and start to relax. It's the physical impact of those leaflets closing that makes the sound we hear.
And as part of their training, doctors learn this crucial skill called auscultation. Listening at very specific points on the chest, the focus cardiacos. These aren't random spots.
Not at all. They're very specific anatomical projections where the sound from each individual valve is best heard. It's about how the sound travels through the chest wall. You listen in different places to isolate the sound of each valve closing.
And is there a way to remember these spots?
There's a great mnemonic the source mentions. Ahora te puedes marchar, which translates to the order. Aortico, pulmonar, tricuspidi, and mitral.
Okay. APT.
Yep. You listen for the aortic valve sound, typically to the right of the sternum, second intercostal space. Pulmonic, ledge of the sternum, same space. Tricuspid, lower left sternal border, maybe fourth or fifth space. And mitral, heard best, right at the heart's apex, near the fifth intercostal space, mid-clavicular line.
Wow. Specific.
Very specific. The source even mentions connecting it to a Luis Miguel song, which is fantastic for making it stick. It's all about positioning that stethoscope just right to hear each valve clearly. Abnormal sounds like murmurs often mean there's an issue. Maybe a valve isn't opening fully, stenosis, or closing properly, regurgitation.
Okay, so we've pushed blood out of the heart's left ventricle through the aortic valve, and now it's entering the arterial network, specifically starting with the mighty aorta. This is truly the master distributor, right? Getting life's essentials to the whole body.
Absolutely.
Yeah.
The aorta comes right off the left ventricle, and it is, hands down, the largest and most vital artery you have. Its huge diameter lets it handle the entire output of the left ventricle. It has several major segments, each playing a role in distributing blood. Understanding these helps map the body's circulation.
It starts as the ascending aorta, going up from the heart, like the name says.
Yep.
Then it takes that big curve, like an upside-down U. That's the arch of the aorta. The source also mentions callado de la aorta, which apparently means like a walking stick handle.
Yeah, it's a charming old anatomical term, callado, like a shepherd's crook or walking stick handle, because of that curve. After that big arch, it straightens out and heads downwards as the descending aorta.
Okay. And the descending aorta gets subdivided too, based on where it is.
Exactly. Based on anatomical landmarks.
Yeah.
Above the diaphragm, that big breathing muscle is called the thoracic aorta, supplying structures in the chest cavity. Once it passes through the diaphragm into the abdominal cavity, it changes name again and becomes the abdominal aorta. This part supplies all the organs in the abdomen and eventually leads down to the legs. This systematic naming helps pinpoint where blood is going.
Now let's talk about those critical branches coming right off the arch of the aorta. These are the big ones fueling your head and arms. Super important. Three main arteries branching off in a specific order.
Very specific order. First, coming off the arch, is the brachiocephalic trunk. It's important that this one doesn't have left or right in its name because it's a single unique vessel that arises first.
Just the trunk.
Just the trunk. This trunk then quickly splits or bifurcates into two main arteries. The right common carotid artery, which goes up to supply the right side of your head and brain,
Okay.
and the right subclavian artery, which dives under your right clavicle subclavian to supply your entire right arm.
Got it. So that's number one, the trunk feeding the right side. What's next?
Then, branching directly off the aortic arch itself is the left common carotid artery. It goes straight up to supply the left side of your head and brain.
Okay. Direct feed for the left head.
And finally, also branching directly from the aorta, is the left subclavian artery, supplying your left arm just like its counterpart on the right.
So wait, why the trunk on the right but direct branches on the left? Seems asymmetrical.
It is asymmetrical, but there's a logical reason. Think about where the aorta starts from the left ventricle, which sits mostly on the left side of your body.
Okay.
So to get blood efficiently over to the right side of the head and the right arm, it needs a slightly longer piece of pipe. Basically, that brachiocephalic trunk acts as an extension.
Ah, like an adapter.
Sort of. Whereas the arteries going to the left side, being closer to the aorta's origin, can just branch off directly. It's elegant anatomical efficiency, really.
That makes sense. Okay, so after supplying the upper body, the aorta continues down as the abdominal aorta, supplying organs along the way. What happens at the end of its run?
Right. The abdominal aorta keeps going down, giving off vital branches to your kidneys, intestines, stomach, liver, all those abdominal organs. We won't detail every single one today, but it's the central conduit. Ultimately, the abdominal aorta finishes its journey by splitting into two very large, powerful vessels, the common iliac arteries. This split, or bifurcation, is a major division point.
Okay, common iliacs, left and right. And they split again?
They do. Each common iliac artery then divides again into an internal iliac artery, which dives deep into the pelvis to supply pelvic organs, buttocks, reproductive organs,
Okay.
and an external iliac artery, which continues down the front, destined for the leg.
And this external iliac becomes the main leg artery we hear about.
That's the one. As the external iliac artery passes under the inguinal ligament end of the thigh, it becomes the femoral artery. Well, you often hear about this one in dramatic medical shows. You know, he's bleeding out from a perforated femoral.
Right.
Because it is a massive vessel, and its branches supply the entire lower extremity, your thigh, lower leg, foot. Absolutely essential for leg function.
All right, so blood's pumping everywhere, head to toe, delivering oxygen. But what about the heart itself? It's this muscle working nonstop. How does the heart muscle get its own fuel? It must need a premium supply line.
That's an excellent and absolutely critical question. It highlights a unique and sometimes vulnerable part of the system. The heart muscle itself, the myocardium, is one of the most metabolically active tissues you have. It needs a constant supply of oxygen and nutrients.
So it has its own plumbing.
It does. It gets its own dedicated blood supply through specialized vessels called the coronary arteries. There's a right coronary artery and a left coronary artery, and they have their own branches that meticulously wrap around the heart's surface like a crown, hence coronary.
And where do these coronary arteries actually start? They must get the good stuff first.
They absolutely do. They have a very privileged origin. They branch directly off the aorta itself, specifically from little pockets or sinuses located right within the aortic valve immediately after the valve closes.
Wow, right at the source.
Right at the source. This is profoundly significant. It means the heart muscle receives the absolute freshest, most highly oxygenated, nutrient-rich blood available in the entire circulation. Essentially, first dibs on the premium fuel.
Like the engine needs fuel just as much as the rest of the car.
Exactly. The heart's transporting fuel everywhere else, but it needs to consume some of that premium fuel to keep its own engine running flawlessly. The coronary arteries are its personal, non-negotiable fuel line. Their health is absolutely paramount.
Now let's shift gears a bit and talk about the heart's incredible internal rhythm, that electrical symphony orchestrating every single beat. Because the heart pumps automatically, right? We don't think about it. It needs incredibly precise timing and coordination.
It's an intricate dance of electrical impulses, a real marvel of bioelectricity. And at the very heart of this system, literally, is the most important, indispensable spark generator.
Right.
A sinoatrial node, usually just called the SA node.
SA node, got it.
You'll also see it called the sinusal node or sinoauricular node, maybe even NSA node in older books. The source really emphasizes you need to know all these synonyms, especially for medical studies, because they all mean this one critical structure.
And where exactly is this SA node located?
It's this tiny bundle of specialized cells strategically located in the posterior upper part of the right atrium, very close to where the superior vena cava enters the heart. And it has a very important nickname that really captures its function.
The pacemaker.
Exactly. It's universally known as the pacemaker of the heart because it has this remarkable ability to automatically generate its own electrical impulses. It doesn't need nerves telling it to fire, it just does it.
Wow.
In a healthy person at rest, this node typically fires at a consistent rate of 60 to 100 beats per minute, setting the fundamental rhythm for the whole heart. It's the conductor of the cardiac orchestra.
So once that initial spark fires off from the SA node, how does that electrical signal spread through the whole heart to make sure everything contracts in the right order? It must follow a specific path, like wiring.
It does, and it's beautifully designed for speed and coordination. The electrical impulse first spreads rapidly across both atria, like ripples in a pond, causing them to contract simultaneously. This atrial kick is important for pushing blood down into the ventricles efficiently.
Okay, so atria contract first. Then where?
From the atria, the impulse travels to another critical structure, the atrioventricular node, or AV node, or AVN sometimes. It acts as a crucial gatekeeper.
Gatekeeper?
Yeah, it's located, as the name suggests, right in the septum between the atria and the ventricles. Its job is to actually delay the impulse for a fraction of a second.
Why delay it?
It's crucial. This brief pause allows the atria to fully empty their blood into the ventricles before the powerful ventricles start to contract. Ensures optimal filling.
Smart design. Okay, so after the delay at the AV node.
From the AV node, the impulse passes into a small, specialized bundle of fibers called the bundle of His, or as de His. This bundle is the crucial electrical bridge. It carries the signal from the atria through the heart's fibrous skeleton, which normally insulates the chambers electrically down into the ventricles.
Okay, crossing the barrier.
Exactly. This ensures the impulse starts activating the ventricles from the bottom up, which helps squeeze blood upwards efficiently.
And then it needs to spread out to all the ventricle muscle, right?
Yeah, precisely. The bundle of His quickly divides into distinct right and left bundle branches, ranas derecha y izquierda, as the source notes. These branches run down the septum and then rapidly distribute the electrical impulse throughout their respective ventricular walls, causing them to contract in this coordinated, almost twisting or ringing motion.
Wow.
This coordinated contraction is what allows the ventricles to eject blood so powerfully. Now, it's important to understand, these electrical pathways, the AV node, bundle of His, the branches, they aren't like copper wires.
Right, not actual wires.
No, they're actually made of highly specialized cardiac muscle cells, uniquely modified just for rapid electrical conduction. These specialized cells are called Purkinje fibers.
Purkinje fibers.
And this isn't just a cool fact. These modified muscle cells ensure an almost instantaneous synchronized contraction across the entire ventricle. If different parts contracted at different times, it would be like trying to squeeze a water balloon unevenly, really inefficient. The Purkinje network guarantees a powerful, unified pump with every single beat.
Now, here's where understanding this electrical system becomes super critical clinically. What happens if this finely tuned orchestra messes up? The source connects this back to the idea of an infarct, like a heart attack.
Right. Imagine if a coronary artery, one of those vital fuel lines supplying the heart muscle we just talked about, gets blocked.
Oh.
Maybe during a severe heart attack.
Okay.
If that specific blocked artery happens to be the one supplying blood to the area where the SA node lives, then that crucial pacemaker tissue, the SA node itself, can die from lack of oxygen. That's ischemia leading to infarction of the node.
And if the natural pacemaker, the SA node, dies or malfunctions badly, the heart loses its normal rhythm, that's 60 to 100 beats per minute. What happens to the person then?
Well, when the SA node fails, the heart's electrical system can become erratic, or more often, it just becomes too slow. That's called bradycardia.
Too slow.
Yeah. And if the heart beats too slowly, it isn't pumping enough blood to meet the body's needs. This leads to symptoms like feeling really tired, dizzy, short of breath, maybe even fainting spells. In severe cases like that, an artificial pacemaker becomes absolutely necessary.
The implanted device.
Exactly.
Yes.
It's a small device, usually put under the skin near the collarbone with wires or leads that go down into the heart. These leads deliver regular electrical impulses directly to the heart muscle, often mimicking the SA node's job or stimulating the ventricles directly. Its purpose is just to make sure the heart maintains a consistent, healthy rate back in that 60 to 100 BPM range, restoring proper blood flow and getting rid of those symptoms.
So it takes over when the natural system fails. But the source also briefly mentioned a kind of built-in backup.
Yeah, the heart does have a fascinating, though less efficient, backup plan. The AV node, that gatekeeper. It also has its own ability to generate impulses, its own intrinsic rhythm.
Oh, okay.
So if the SA node completely fails, the AV node can sometimes take over as a substitute pacemaker. But, and this is a big but, it does so at a much slower rate, typically only 40 to 60 beats per minute.
Slower than the SA node.
Much slower. And while that might be enough to keep someone alive in some situations, it's often not enough for normal activity levels. Whether that slower rate is okay or if someone still needs an artificial pacemaker really depends on the individual patient, their symptoms, their overall health. Medical decisions are always tailored, always focused on quality of life and making sure organs get enough blood.
Okay, so we've traced blood through the heart, its chambers, its valves, the electrical control, and out through the major arteries. But how does it actually get down to the individual cells, do the exchange, and then make its way back? Let's zoom right in now into the microcosm of circulation, the tiny vessels.
This is where the real magic of exchange happens, right down at the cellular level. Let's outline the full sequence again from the heart and back, this continuous circuit. It starts with the large arteries, which branch into smaller arteries, then into even smaller arterioles.
Okay.
From arterioles, blood flows into the incredibly tiny capillaries. These are the exchange sites. After the capillaries, blood enters small venules, which then merge into larger veins, finally returning the blood back to the heart. Arteries, arterioles, capillaries, venules, veins, heart.
A precise hierarchy. And it's a constant loop, right? Happening everywhere, body and lungs. But each of these vessel types has a very specific, critical job to do.
Absolutely critical roles, and quite distinct.
Yeah.
Let's start with the arterioles. Often overlooked, but incredibly important. They're the primary regulators of resistance to blood flow in the system.
Resistance, how so?
They have smooth muscle in their walls that can contract or relax. Think of them as tiny adjustable taps or valves all throughout your body. By constricting, narrowing, or dilating, widening, they control how much blood flows into the capillary beds downstream.
Ah, so they control local blood flow.
Exactly. And because there are so many of them, their overall constriction or dilation has a massive impact on your systemic blood pressure.
Right. So in shock, doctors give vasoconstrictors to squeeze the arterioles and raise pressure.
Precisely. Or in chronic high blood pressure, hypertension, the arterioles might be persistently constricted. Their ability to precisely control flow distribution is key. Now, then we get to the capillaries. These are, without doubt, the unsung heroes.
Exchange hubs.
These exchange hubs. They're the smallest blood vessels, the walls are only 1 cell thick, and crucially, they're the sole site of exchange for everything, oxygen, nutrients like glucose, hormones, immune factors going out to the tissues, and for waste products like CO2 and metabolic byproducts coming back into the blood.
So in my muscles or brain, capillaries deliver the O2 in food and pick up the CO2 in trash.
Perfect analogy. A continuous microscopic transaction. And then in the lungs, the process is perfectly reversed.
Right, drop off CO2, pick up O2.
Exactly. CO2 is released to be exhaled. Fresh oxygen is picked up by red blood cells. This bidirectional exchange happens only in the capillaries. No other vessel type does this.
Okay. Next in line, venules, connecting capillaries to veins, beginning the return trip.
Yep. And while they're often seen as just connectors, venules have a specific role too, especially in immunity. They're often described as the exit points for white blood cells.
Exit points.
Yeah, immune cells like neutrophils or macrophages can actually squeeze between the cells of the venule wall to get out of the bloodstream and into surrounding tissues where there might be an infection or inflammation.
Wow, they squeeze through.
It's called diapedesis or extravasation. They literally deform themselves to get through tiny gaps. It allows them to reach the site of infection and start fighting. Pretty amazing cellular acrobatics.
Definitely. Okay, finally, the veins. Collecting all that blood, bringing it back home to the heart. The source highlights a really important characteristic of veins: capacitance.
Yes, veins are famously known as capacitance vessels. It accurately describes their ability to be highly distensible, very stretchy. Unlike arteries, they can store a huge volume of blood. Up to 80% of your total blood volume can be sitting in your veins at any given moment.
80%, wow.
Yeah, they act as a vital blood reserve or reservoir. It can handle big shifts in blood volume without massive pressure changes.
And that ability comes down to their structure being different from arteries.
Absolutely. Arteries, remember, have thicker, more muscular, more elastic walls. They need that strength to handle high pressure from the heart and help push blood along. Veins have significantly thinner, less muscular, less elastic walls. They're much more collapsible.
Like flattened bags.
Exactly. If you saw them empty in an anatomy lab, they often look like flattened bags, not rigid tubes like arteries. This fundamental difference in muscle and elastic tissue content is key to their different jobs. Arteries handling pressure, veins handling volume.
So veins are these capacitance vessels bringing blood back, but especially from the legs and arms, they're fighting gravity the whole way. How do they manage to get blood all the way back up to the heart?
This is where another really ingenious feature comes in: valves inside the veins. Remember, arteries don't need valves. The pressure gradient takes care of flow direction. But veins, especially in the limbs, absolutely do have valves.
Ah, yes, to stop blood falling back down, especially in the legs. The source said they work just like heart valves.
Identical principle. Little flaps that allow blood to flow only one way towards the heart, and then they snap shut to prevent any backflow or pooling when pressure drops.
Clever, but that can't be the whole story against gravity.
It's not. This system gets a massive assist from something called the muscle pump. When your skeletal muscles contract, like when you walk, run, or even just flex your calf muscles, they squeeze the veins running through or between them.
Ah, the muscles squeeze the veins?
Exactly. This compression acts like an external pump, literally milking the blood upwards, segment by segment, towards the heart.
And the valves stop it falling back down between squeezes.
Precisely. The valves ensure that upward pushed blood stays up. It's a fantastic collaboration between your muscles and those tiny valves, constantly working to defy gravity. This is why moving around is so important for good circulation, especially preventing clots on long journeys or if you're immobile.
And when this elegant system breaks down, that's when we see problems like varicose veins or varicose syndrome.
Exactly. That's a condition where those venous valves become damaged, leaky, or just ineffective. Blood starts to pool, especially in the legs, causing the veins to stretch, bulge, and become visible. Those are varicose veins.
And it's not always just cosmetic, right? The source mentioned it can get quite serious.
Oh, definitely. It ranges from small, superficial spider veins, raidas, that might be mostly cosmetic, to much larger bulging veins that can cause real symptoms: aching, heaviness, painful leg cramps, especially after standing. In severe chronic cases, it can lead to skin changes, inflammation, and even difficult-to-heal venous ulcers near the ankles. Plus, that pooled, stagnant blood increases the risk of blood clots forming, DVT.
So what's the main way to manage or prevent this?
For management, especially early on, or for prevention, the single most effective thing is usually compression stockings.
The tight socks?
Yeah, the graduated compression ones. They apply external pressure, tightest at the ankle, decreasing upwards. This physically helps squeeze blood back up, supports the vein walls, prevents them from overdistending, and basically assists the failing valves and muscle pump. The source really emphasizes this over just curious remedies or pills alone. Compression is key.
And there's an interesting gender difference here. More common in women? Why is that?
It is notably more common in women. This is largely attributed to hormonal factors, primarily higher circulating levels of progesterone.
Progesterone. How does that affect veins?
Progesterone tends to relax smooth muscle, including the muscle and vein walls, making them more pliable, more likely to stretch or dilate. It can also contribute to fluid retention, which increases pressure in the veins. Over time, these effects can strain the valves and walls, leading to varicose veins. There might be some anatomical factors too, but the hormonal influence is significant.
Fascinating. Okay, now for the grand finale of our deep dive. Putting all this knowledge to work clinically, understanding and, crucially, distinguishing between different types of infarcts. This is where it all comes together.
Yes. The term infarct itself just means tissue death necrosis caused by a severe lack of blood supply, which we call ischemia. And that ischemia is caused by some kind of blockage, an obstruction of the arterial blood flow to that tissue. Our goal now is to use our knowledge to clearly differentiate between things that might get lumped together like a stroke or a heart attack, because their underlying causes and locations are very different.
So let's start with a classic case study that illustrates a pulmonary embolism, sometimes called an infarto pulmonar. The source paints this picture. An elderly woman, maybe 70s or 80s, has osteoporosis, brittle bones. She stumbles at home, fractures her hip. She's hospitalized, waiting for surgery, pretty much immobile in bed for maybe 2 weeks.
Okay, immobile for a while. Then she has successful hip surgery, but she's still recovering, still mostly immobile for another week or two, following doctor's orders. Then finally the day comes. She gets clearance to try walking for the first time since the fracture. She stands up, takes a few steps, and suddenly clutches her chest, gasps for air, feels terrible sharp pain, and collapses.
Wow, that's dramatic.
It is. And medically, that is a classic textbook presentation of a pulmonary embolism. Or, more specifically, a thromboembolism, a clot that formed somewhere else and traveled.
So what actually happened inside her body? The source explains that prolonged immobility, like she experienced, leads to blood stasis. Blood flow slows right down, especially in the deep leg veins.
Exactly. That stagnant blood, maybe combined with a little vessel irritation from the surgery or just an underlying tendency, allows blood clots to form in those deep veins of her legs. That's deep vein thrombosis, or DVT.
And these clots just sit there quietly.
Often, yes. They could be completely asymptomatic while forming. But then when she finally stands up and starts moving, her leg muscles start contracting that muscle pump we talked about.
Oh, the pump kicks in.
Yes, and that sudden compression on the veins can dislodge one or more of those clots. Now, they're not thrombing anymore. They're embolent traveling clots sent on a very dangerous journey through her circulation.
Okay, so knowing the blood flow, we can trace this clot. It leaves the deep leg vein, goes up the femoral vein, then the iliac vein, into the huge inferior vena cava. Keep going. Into the right atrium, through the tricuspid valve to the right ventricle, then pumped out into the main pulmonary artery.
Perfect. Which then branches into right and left pulmonary arteries heading to the lungs.
Yeah. Okay. And then
The critical point is the clot travels through bigger and bigger vessels until it reaches the lungs. There, the arteries branch into smaller and smaller vessels, eventually leading to the tiny pulmonary capillaries. The clot gets stuck there. It's too big to pass through those microscopic capillaries.
like a blocked pipe.
Exactly like a block pipe. This sudden blockage cuts off blood flow to a section of lung tissue. That tissue can't get oxygen, can't do gas exchange, and can die. That's the infarto pulmonar, the pulmonary embolism.
Which explains the sudden breathing difficulty, the chest pain, the collapse. The body isn't getting oxygenated properly. So if a doctor suspects this, maybe after someone collapses, what's the diagnostic step?
Well, if they suspect the source might be a DVT in the legs, they'd likely order a Doppler ultrasound of the legs to look for clots there. To confirm the PE itself in the lungs, they might do a blood test called a D-dimer, which indicates clotting, and often a CT pulmonary angiogram, a special CT scan that visualizes the blood vessels in the lungs to see the blockage directly.
And prevention. This sounds preventable.
Hugely preventable. This case powerfully illustrates why prevention is key for any immobile patient. Post-surgery, coma patients, long hospital stays, even long flights. The mainstays are anticoagulant medications, blood thinners to stop clots forming, compression stockings to help venous return, and encouraging early movement or leg exercises whenever possible. We absolutely have to keep that blood moving.
That's a fantastic, detailed example connecting anatomy to a real clinical event. Okay, let's shift to a different type of infarct. A cerebral embolism, an infartocerebral, or what most people call a stroke, specifically an ischemic stroke. What's the typical scenario here?
Okay, imagine another scenario. An elderly man. His family suddenly notices he has some distinct neurological problems. Maybe one side of his mouth is drooping, his speech is slurred and hard to understand, and one arm is weak, maybe hanging limp, he can't lift it properly. These are classic sudden signs of a brain function disruption.
People might call it a derame, like a bleed, but the source says it's more precise to say CDA, cerebrovascular accident, stroke, or specifically embolia cerebral if it's from a traveling clot.
Exactly. Now, if we trace the clot's origin in this case, it must have traveled to the brain. That means it came up via the carotid arteries supplying the head. So where did this clot likely start? It didn't come from the legs this time.
Right, different source. The most common origin, according to the source, is a heart rhythm problem called atrial fibrillation, or AFib, specifically happening in the left atrium.
That's the #1 culprit for embolic strokes. AFib is where the atria don't contract properly. They just sort of quiver chaotically and ineffectively.
Like a bag of worms.
That's a common description. Because they're not contracting strongly, blood can become stagnant and pool, especially in a little pouch off the left atrium called the appendage. And stagnant blood loves to form clots.
Ah, so the clot forms in the heart's left atrium due to AFib. Then where does it go?
Once that clot breaks free, its journey is from the left atrium gets flushed into the left ventricle, then pumped out into the mighty aorta. From the aorta, it can easily travel up into the carotid arteries heading to the brain, and then into smaller and smaller brain arteries until it gets lodged.
And even a tiny clot can cause big problems in the brain.
Absolutely. The brain is exquisitely sensitive to lack of blood flow. Even a small clot blocking a small artery can kill off neurons and cause significant, lasting neurological deficits, like the weakness, speech problems, or facial droop we described.
So if a doctor suspects this kind of stroke, what are the key diagnostic tests?
First, they'd likely do an electrocardiogram, ECG or EKG, right away to check for atrial fibrillation, looking for that telltale irregular rhythm. An echocardiogram, ultrasound of the heart, might be done to look for clots directly in the left atrium or assess overall heart function. And to see the stroke itself in the brain, and importantly to rule out a bleed, hemorrhagic stroke, they'd order an urgent CT scan or MRI scan of the head.
Makes sense. The source also mentioned hypertension, high blood pressure as a risk factor.
Yes, chronic high blood pressure damages blood vessel walls over time, making them more susceptible to plaque buildup, atherosclerosis, and also increasing the stress on the heart, which can contribute to developing AFib. So it's a major underlying risk factor for stroke.
Okay, clear distinction between pulmonary and cerebral embolisms based on where the clot comes from and where it goes. Now, the big one, myocardial infarction,
Yeah.
infarto cardiaco, the classic heart attack. What's fundamentally different here?
This is the one people usually mean when they say heart attack. And yes, it's distinctly different in its direct cause and location. The problem here is specifically within the heart muscle's own blood supply system.
So what causes it? Not a clot traveling from somewhere else?
Generally, no. It's caused by the obstruction of the coronary arteries themselves, those dedicated fuel lines supplying the heart muscle. And the most common reason for that obstruction is atherosclerosis.
Plaque buildup.
Exactly. That slow buildup of fatty plaques, mostly from cholesterol, inside the coronary arteries. This plaque narrows the artery over time, stenosis. A heart attack typically happens when one of these unstable plaques suddenly ruptures.
The plaque breaks open.
Yes, and the body reacts to that rupture by forming a blood clot right on top of it, trying to heal the injury. But that clot can rapidly grow large enough to completely block the already narrowed artery,
And that cuts off blood flow to the heart muscle downstream.
instantly cutting off blood supply to a segment of the heart muscle. That muscle tissue starts to die from lack of oxygen. That's the myocardial infarction.
And the symptoms. We know the classic ones, but good to reiterate.
The classic is that intense, crushing chest pain or pressure, often described like an elephant sitting on the chest. Very commonly, it radiates spreads to the left arm, sometimes the jaw, neck, or back. That pain is the heart muscle crying out for oxygen, myocardial ischemia. Other signs can include shortness of breath, sudden sweating, nausea, lightheadedness, extreme fatigue.
So prevention and treatment here have to focus on those coronary arteries and the plaque.
Absolutely. Prevention is all about managing risk factors for atherosclerosis. Healthy diet, low saturated fat, low cholesterol, regular exercise, not smoking, controlling high blood pressure and diabetes, and often cholesterol-lowering medications like statins.
And if someone is having a heart attack,
The goal is emergency treatment to open that blocked coronary artery as fast as possible.
Yeah.
That might involve clot-busting drugs, or more commonly now, procedures like angioplasty, inserting a balloon to open the artery, often placing a stent to keep it open, or sometimes coronary artery bypass surgery. Time is muscle. The faster you restore blood flow, the less heart muscle dies.
the source also mentions strong emotions can trigger one.
Yes, that's an interesting point. In someone who already has significant underlying atherosclerosis, intense stress or anger can trigger an event. It causes a surge in stress hormones, makes the heart beat faster and harder, increasing its oxygen demand. If the narrowed arteries can't deliver enough extra oxygen to meet that sudden demand, it can precipitate an infarction. The emotion is the trigger, but the underlying disease was already there.
So wrapping up this section on infarcts, there's a universal principle that ties them all together, regardless of where they happen.
The core concept is simple but powerful. Any tissue in your body, if its arterial blood supply gets critically blocked, can suffer an infarct. Doesn't matter if it's lung tissue, pulmonary embolism, brain tissue, stroke, or heart muscle tissue, myocardial infarction. The mechanism is the same. Obstruction, ischemia, lack of blood flow, infarction, tissue death. Understanding this unifies how we think about these critical events.
All right, it's time now to shine a much-needed spotlight on our unsung hero, the lymphatic system. Often ignored, barely mentioned sometimes, but it plays a profoundly important role way beyond just dealing with fluid.
Absolutely.
Yeah.
As we touched on earlier, the lymphatic system does not transport blood. It's a completely separate, yet equally vital circulatory network. Its main jobs are fluid drainage, immune surveillance, and actually even absorbing certain fats from your diet. It really is the unsung hero, constantly working behind the scenes.
So let's revisit that fluid drainage role. Where does the fluid come from, and what does the lymphatic system do with it?
It starts right down in your tissues, at the capillary level. A small amount of fluid, derived from blood plasma, naturally leaks out of the blood capillaries into the surrounding spaces between your cells. This fluid, called interstitial fluid, contains water, proteins, other substances.
Okay.
The lymphatic system's job is to collect this excess interstitial fluid. Tiny lymphatic capillaries interwoven with blood capillaries soak it up. This collection is vital. It prevents fluid from building up in your tissues, which would cause swelling or edema.
So it's like a drainage system for the tissues.
A very efficient one-way drainage system. Once inside the lymphatic vessels, this fluid is called lymph. The lymphatic vessels then transport this lymph away from the tissues, eventually returning it back into the bloodstream near the heart.
But it doesn't just dump it straight back in, right? The source mentioned inspection points.
Yep,
Points.
Exactly. As the lymph flows through the network of lymphatic vessels, it gets filtered through strategically placed bean-shaped structures called lymph nodes.
Ah, the lymph nodes, the bolitas or little balls, the checkpoints. What exactly happens inside them?
They are critical immune surveillance centers, like sophisticated biological filters. They're packed densely with immune cells, lymphocytes, T cells, B cells, macrophages, dendritic cells. As the lymph fluid percolates slowly through the node, these immune cells constantly inspect it,
Looking for trouble.
looking for trouble. Signs of infection, bacteria, viruses, foreign particles, damaged cells, and importantly, cancerous cells that might have broken free from the tumor. If they detect a threat, the immune cells in that node activate, multiply, and launch an immune response to deal with it. They are vigilant sentinels.
Which leads directly to the clinical significance. Why are lymph nodes so important in medicine?
Well, for one, when a doctor feels your neck and finds swollen, tender lymph nodes, that's usually a sign of infection nearby, like a sore throat or ear infection. Those nodes are swollen because the immune cells inside are multiplying rapidly to fight the infection in the area they drain.
Okay, swollen nodes, infection nearby.
Often, yes. But critically, they are hugely important in cancer staging and treatment.
How so?
Cancer cells can break away from a primary tumor and travel through the lymphatic system. This is a common way cancer spreads or metastasizes. So in cancers like breast cancer or melanoma, surgeons will often perform a sentinel node biopsy.
Sentinel node.
That's the very first lymph node that drains the fluid from the area of the tumor. They remove it and examine it under a microscope. If cancer cells are found in that sentinel node, it means the cancer has started to spread
And that changes treatment.
dramatically. It tells the doctors the cancer stage is more advanced, and the patient likely needs more extensive treatment, like removing more lymph nodes or adding chemotherapy or radiation therapy to target potentially hidden cancer cells elsewhere. The lymph node status is a crucial guide for treatment planning.
Wow, okay. And finally, what if the lymphatic system itself just doesn't work properly? Maybe it gets damaged.
If the lymphatic system malfunctions, maybe it's damaged by surgery like lymph node removal, radiation therapy, infection, or even some congenital conditions, it can't collect that excess interstitial fluid effectively.
So the fluid builds up?
Exactly. The fluid accumulates in the tissues, leading to chronic swelling. This condition is called edema, or more specifically, lymphedema, when it's caused by lymphatic failure. It often affects limbs and can be quite debilitating. It really highlights how essential this unsung system is for maintaining normal fluid balance in your body. Its integrity is just as vital as the cardiovascular systems.
Wow, what an absolutely incredible journey we've taken today. Seriously. From the mighty heart, that tireless pump fueled by its own coronary arteries, orchestrated by that amazing electrical symphony.
Yeah, all the way through the intricate network of arteries delivering life, the veins bringing it back, working against gravity with valves and muscle pumps.
And finally, giving the lymphatic system its due, that crucial drainage and surveillance network. We've covered how blood flows, how valves work like perfect one-way doors, how electricity keeps it all timed.
And really importantly, we connected all that fundamental anatomy and physiology to real-world clinical situations. You now have the tools to understand the difference between a heart attack, a stroke originating from the heart, and a pulmonary embolism originating from the legs.
Right, understanding where the problem starts, the clot's journey, why the symptoms are different, it's empowering knowledge.
It really demystifies things that can sound complex or scary. Having that foundational understanding helps you process health information much more clearly.
This deep dive has truly equipped you, our listeners, with fundamental knowledge to understand your own body better and to grasp some of the most common and critical medical conditions out there. It really is powerful, practical stuff.
So here's a thought to leave you with as you go about your day. Just consider for a moment this profound interconnectedness we've discussed. How deeply intertwined are your everyday actions? What you choose to eat, how much you move your body, how you manage stress, with the intricate moment-to-moment workings of this entire cardiovascular and lymphatic system.
Yeah, it's not just happening to us, we're actively influencing it constantly. Maintaining its health isn't just about hoping for the best, it's a continuous conscious effort. And understanding it is the first step.
Reflect on the incredible power you actually have in influencing your own cardiovascular well-being simply through the deliberate choices you make every single day.
The more you understand this internal marvel, the better equipped you are to care for it. Keep learning, everyone. Keep asking questions and keep exploring.